And then you guys can take it away.
Okay, so hi, my name is Chelsea Wanwu. I'm a third-year medical student from UC Riverside. And
Hi, my name is Tan Tran. I'm a first-year medical student at UC Riverside.
and we're going to be doing the review article on vertebroplasty versus active control intervention for chronic osteoporotic vertebral compression fractures. So next slide. Okay, so overview, we're going to do the clinical context of osteoporotic vertebral compression fractures. So we're going to start with epidemiology, pathophysiology, clinical presentation, diagnostic workup, medical and interventional radiology treatment options, and post-procedure management. Then we're going to go on to the journal, which is the VERTOS V trial, and talk about the rationale and objectives, study design, results, and discussion. So osteoporotic vertebral, just a background, osteoporotic vertebral compression fractures, or OVCFs, are a critical health concern due to their high prevalence and severe impact on quality of life. They occur when weakened vertebral collapse, often due to osteoporosis. It affects over 10 million Americans, predominantly postmenopausal women, where declining estrogen levels accelerate bone loss. And these fractures can cause chronic pain, deformity, and loss of independence. So like imagine a patient who was once active, now needing a cane or a walker, not just due to pain because of spinal instability and kyphosis. And beyond the physical burden, there is a profound economic impact, an average of $35,000 in healthcare costs per fracture, not including loss of productivity or caregiving needs. So continue on, 1 in 3 women and 1 in 5 men over 50 will experience an osteoporotic fracture in their lifetime, making OVCFs a substantial public health issue. And these fractures predominantly occur in the mid-thoracic spine or the thoracolumbar junction region, because they have significant biochemical stress. Risk factors include aging, corticosteroid use, low bone mineral density, and falls. Interestingly, OVCFs often go undiagnosed because the pain can be misattributed to just old aging, normal aging. And the delay recognition contributes to further complications such as progressive deformity or increased fracture risk. And another critical point is that prior fractures increase the risk of future fractures, a phenomenon also described as the domino effect, and it highlights the importance of fracture prevention strategies and osteoporosis management. Okay, next slide. Okay, so I'm going to do like a really brief overview of the pathophysiology. So OVFCs are fundamentally disrupted in bone remodeling, and bone remodeling is a continuous process involving osteoclast-mediated bone resorption and osteoblast-mediated bone formation. And in healthy bone, these processes are balanced, ensuring structural integrity and repair. So first, I'm going to talk about the rank and rank L and OPG pathway, which is the pathway involved in bone homeostasis. So rank L is secreted by osteoblasts and osteocytes, which, when stimulated by parathyroid hormone, vitamin D, or prostaglandin E2, rank L then binds to rank on the membrane osteoclast progenitors, which results in bone reabsorption by mature osteoclasts. And osteoprotein, OPG, binds to rank L, thus inhibiting rank signaling and bone reabsorption. So in osteoporosis, there is either a relative decrease in OPG or increase in rank L, leading to excessive osteoclast activity. And this dysregulation results in porous, fragile bones that are highly susceptible to fractures. And specifically in osteoporosis, there's many reasons that can cause this imbalance. So for example, hormonal changes. So in postmenopausal women experience a dramatic drop in estrogen, a hormone that normally inhibits osteoclast activity by increasing osteoprotein and suppressing rank L. So this loss in protective mechanisms leading to unchecked osteoclast activation and accelerated bone reabsorption. And then age-related change. So with aging, osteoblasts become less active and bone matrix synthesis declines, further tipping the balance toward bone loss. And nutritional deficiencies, so inadequate calcium or vitamin D impairs mineralization, weakening the bone's ability to withstand mechanical loss. And then with osteoporosis, it affects the cortical and trabecular bone, but its impact is more pronounced in trabecular bone due to higher turnover rate. And the vertebrae are particularly susceptible to these changes because they are composed of higher proportion of trabecular bone compared to long bone. This makes them more prone to compression fracture, especially under stress of normal physiological activities like walking or lifting. And so with the mechanism of vertebral collapse, the vertical loading force exceeds the weakening bone capacity, causing collapse of the vertebral body. And this leads to a reduction in the vertebral height and a change in the spine alignment, often resulting in kyphosis. And the collapse may compress adjacent structures, including nerves, leading to pain that's radiating or neurological deficits in severe cases. Next slide. Okay. So with osteoporosis factors, so what I was saying before, they can be caused by weakened bone due to osteoporosis, typically leading to vertebral cross. And again, with the lifetime balance, it can cause chronic pain, deformities, and functional impairment, and economic burden, which really have an effect on not only patient outcomes, but financial burden of them as well. You can go next slide. So for clinical presentations, they would often start with acute localized back pain following minimal trauma. This pain is typically sharp, exaggerated by movement or weight bearing. Over time, patients may develop postural changes such as kyphosis and functional impairments that interfere with daily activities like walking or bending. And it's important to recognize red flags such as neurological symptoms, including weakness, bladder dysfunction, because these signs can indicate spinal cord compression and require urgent intervention. The challenges, however, is that some OVCFs remain asymptomatic, making routine assessments of high-risk individuals critical. And then the next slide. Okay, so actually, does anyone in the group want to give what do you think someone will come in a detailed history you would ask, or what questions you would ask if you had a patient with potential fractures from the audience?
Yeah, I mean, in relation to just a couple things, but I mean, in addition to just their general history, like age and things like age, gender, obviously, and things like that. You want to obviously ask about medication history. So are they taking some of these medications from before? And then just kind of for the actual workup of whatever fracture that they have, what is the mechanism of the fracture? Was it just a ground level fall? Was it some kind of actual trauma? Because then something that is if they have normal bone health, it's not really going to be a compression fracture that you're thinking of if it's a high mechanism or high impact injury. But if it's something like a ground level fall, you're oh, well, that shouldn't be happening in a normal healthy person. So then maybe that's something that would point you towards that in the right demographic.
Thank you. So yeah, exactly what you were saying, that would be good questions to ask. And then I already have it on slide, but I was gonna ask any what would be your next step in management, which was labs, so CBC, CMP, or does anyone know particularly what we're looking for in the CMP? I'll just say it. So basically, we wanted so for CBC, we want to rule out anemia or leukocytosis, which may suggest malignancy or infection. Also with the CMP, particularly includes calcium and phosphate levels, so that can assess the bone turnover. And then more like bone specific labs include 25 hydroxy vitamin D, and low levels are common in osteoporosis and can impair bone mineralization, as well as parathyroid hormone. So elevated levels may indicate secondary hyperparathyroidism contributing to bone reabsorption. And particularly in men, serum testosterone, because hypogonadism is a key risk factor for osteoporosis, and alkaline phosphatase, because elevated levels may indicate increased bone turnover, common in metabolic bone disease. Okay, next. And then for imaging, first line will be X-ray, which can have like the lateral and apical views to assess any deformities. MRIs are good for assessing the soft tissue injuries and also to rule out any malignancy or spinal cord compression. It's also helpful for bone marrow edema, and the presence of bone marrow edema is a predictive factor for improvement in augmentation. And then there's also, you can do MRI or CT scan. And then for bone, for DXA scan, usually we use that for screening, but it's also used to assess the osteoporosis severity or fracture risk. Okay, next slide. Okay. So for treatment options, so conservative management remains the cornerstone of an individual OVCF treatment. And pain, so like for mild cases, they respond to like NSAIDs or acetaminophen or naproxen, and also with intranasal calcitonin, while severe pain necessitates possibly a short-term opioid like tramadol, and then also bracing. Depending on where you read it, like you get mixed reviews, but like some say that it can stabilize the spine and elevate pain in acute phases, but not necessarily used for long-term use because it can cause muscle atrophy. And physical therapy and plays a vital role, as well as exercise, focusing on core strengthening and postural training to prevent future fractures. And then for long-term treatment, so like treating the underlying cause of OVCFs, which is osteoporosis, those will include like bisphosphonates, densimumab, parathyroid hormone, and vitamin D to prevent future bone loss. Okay, so now for the IR treatment options. So minimally invasive options include vertebroplasty, kyphoplasty, as well as mechanical augmentation. And these are mostly safe for like chronic diagnosis. With vertebroplasty, it involves injecting polymethyl methacrylate cement into collapsed vertebra, stabilizing it, and providing rapid pain relief. Patients often report significant improvement within for pain relief in 24 to 48 hours. And then kyphoplasty goes a step further compared to vertebroplasty by using a balloon to inflate the vertebral, and then you inject cement. And this one's more particularly effective in cases with severe collapse, improving both pain and functional outcomes. And then there's also mechanical vertebral augmentation, such as Kiva and spine jack, which is a technique that uses a implant for structural support of the vertebral body to provide a reservoir for bone cement. And it helps to restore vertebral height, shape, in addition to providing support and somatic relief. Next slide. And then, also for I mentioned, but for like vertebral kyphoplasty, they're considered safe, but they do collude with risks. So short-term complications occur prominently due to extravasation of the cement and may include increased pain, damage, or heat from the spinal cords removed. It can also cause some sources say like cement embolization. Possible long-term complications include local acceleration of bone reabsorption caused by treatment itself, or foreign body reaction as the cement bone goes into the body. It can also lead to infection. Some say fibrotic tissue, foreign bone reaction, and necrosis. But generally considered safe. And pain relief, again, like usually see improvement in 24 to 48 hours. And with most surgeries, you want to limited weight bearing for a short period after vertebroplasty and kyphoplasty. and mechanical augmentation. Okay. Next slide.
Okay, let me unmute. Can you guys hear me just fine? Okay. So thank you so much, Chelsea, for presenting the clinical context. As I'm presenting the clinical trial, Chelsea, can you please take a look at chat? I think there's been some questions, I believe, or comments. Okay. So just to recap, I am presenting the VERTOS V randomized controlled trial tonight. It is the vertebroplasty versus active control interventions for chronic painful OVCF. Let's see. Okay, so let's start with the background and the rationale for the VERTOS V trial. Previous studies have explored PV in cases of acute OVCF. Studies like the VERTOS II, where they compare PV with conservative therapy in an unblinded randomized controlled trial. And their results suggested that patients with ongoing pain at 3 months could benefit from PV. Similarly, the VERTOS IV trial, which is a sham-controlled blinded randomized controlled trial, their result demonstrated benefits of PV in acute fractures. However, they found that 40% of the control group still experience disabling pain at 12 months. So this highlights a gap in treatment for persistent or chronic cases of OVCF. So this brings us to VERTOS V. Chronic painful fractures lasting more than 3 months have limited evidence supporting PV. And additionally, given the persistent pain seen in the control groups of previous trials like VERTOS II and IV, VERTOS V aimed to assess whether PV could improve pain relief, quality of life, and functionality in these patients compared to active control using anesthetic infiltrations of lidocaine and bupivacaine. I'm going to butcher that name, so please bear with me. Anesthetic injection. So study design. This is a blinded randomized controlled trial, and they were conducted between May 2013 and June 2019. So their blinded randomized controlled trial means participants, internists, and outcome assessor were blinded, and they remained blinded during the 12 months follow-up. As for participants' inclusion criteria, they must be 50 years or older. They must have chronic back pain with a VAS scores or the pain scores of 5 or greater for 3 months or longer. They must also have 1 or more OVCF with a vertebral height loss of greater than 15%. They also must have the bone density T-scores of less than -1, as well as bone edema on MRI. And they were excluded from the study if they had severe cardiopulmonary conditions, coagulopathy, or underlying diseases. As for randomization, so there were a total of 232 individuals selected for eligibility. Out of 232, 152 declined to participate, leaving them with only 80 participants. So 80 participants were randomized 1-to-1 ratio, and they were 40 of them were allocated into the PV group and the other 40 in the active control group. In the PV group, there were a total of 72 fractures with a mean age of 69 years old. There were 27 women and 13 men. In the active control group, there were a total of 63 fractures with a mean age of 71 years old. And like the PV group, there were 27 women and 13 men. As for the fracture characteristic, most vertebral fractures were wedge-shaped, and they were localized in the thoracolumbar junctions, and they were predominantly single vertebral single vertebral fractures. Okay, study design continue. So for interventions, there are PV group and active control group. The PV group underwent subcutaneous anesthetic infiltration with lidocaine and bupivacaine, and then follow up with cementation with polymethyl methacrylate. In the active control group, they only underwent an anesthetic infiltration. So cementation was only simulated for them, so they can believe that they also received the PV intervention as well. As for primary outcome, the primary objective for this study was to compare PV with and active control treated groups to determine the difference in pain reduction based on the visual analog scale, which is VAS, at baseline and during the 12 months follow-up. The secondary objectives were to determine the differences between groups in mean changes of health-related quality of life and physical functioning during the 12 months follow-up. And for the quality of life, they were assessed using the Qualifo test. For the physical functioning is the Roland-Morris Disability Questionnaire. As for the data were collected at 1 day, 1 week, 1, 3, 6, and 12 months. All right, for the result. So these are the result from baseline, 3 months, and 12 months because they're statistically significant. So for the primary outcome that they looked at were pain relief. So they looked at the, the mean VAS scores. So compared to baseline, a significant reductions in mean VAS score was observed in both the PV and active control group at all measurement points during the 12 months period. In the PV group, the mean VAS scores decreased from 7.6 at baseline to 3.5 at 3 months and to 3.9 at 12 months. The p-value for this was less than 0.001, so it's statistically significant. Similarly, in the active control group, the mean VAS scores decreased from 7.3 to 4.9 at 3 months and to 5.1 at 12 months, with also a p-value of less than 0.001. So there were definitely significant reductions within each group. However, when we compare both groups together, this reductions in mean VAS scores was stronger in the PV group. So from baseline to 12 months, the mean VAS scores declines by 3.6 for the PV group and only 2.3 for the active control group. So because pain reductions in PV group was greater, this indicates that the relationship between VAS scores and time is dependent on treatment group. The secondary outcome they measure is the health-related quality of life. A similar pattern of improvement was observed for the quality of life score, and there is significant differences between groups in the changes across 12 months. As for the functionality test assessment, both groups shows improvement in the functionality scores during the 12 months follow-up. However, there was no significant differences observed between the two group from baseline to 12 months. There were, if we are looking at 3 months, there was differences between the two groups, and it was statistically significant with a p-value of 0.04. But for the 6 and 12 months, it was not there anymore. So we said there's no significant between group differences. And this is table 3 taken from the article. It just shows us all the data collected for the 3 outcomes at the various time during the 12 months period. All right, result continue. This trial also looked into additional outcome measures in PV and active control group. The first outcome measure they looked into was analgesic use over the 12 months follow-up in both groups. In the PV group at baseline, 40% of participants received strong opiates, 25% received weak opiates, and at 12 months follow-up, strong opiates use decreased from 40% to 17%, with a p-value of 0.04. And weak opiates use decreased from 25% to 5.9%, with a p-value of 0.03. And additionally, the percentage of participants with no medicine intake increased from 10% to 40%, in the PV group. On the other hand, for the active control group, strong opiates use went from 23% to 14%, and weak opiates use went from 13% to 8.6%, with a p-value of 0.72. So it's a minimum change in opiate use with no statistically significant difference. There were also no significant difference in increase in no medicine intake as well. So moving on to the fracture treatment outcome. In total, there were 135 fractures treated with 100% technical success in both groups. PV was, just a recap, PV had 63 fractures and active control has 72 fractures. And there were also no increased risk of adjacents or new fractures. All right, discussion. So there were previous randomized controlled trial have shown conflicting results on the effectiveness of PV in acute cases of OVCF. For example, two New England Journal of Medicine's randomized controlled trial comparing PV versus sham intervention show no benefit of PV for acute OVCF. On the other hand, VERTOS II, where they compare PV versus conservative therapy, and VAPOR, another randomized controlled trial that compared PV versus sham intervention, they found effective pain relief in the PV group. Similarly, VERTOS IV and VAPOR found better protections of vertebral body height after PV in patients with acute OVCF. So previous trials like VERTOS II and IV suggested that PV could be beneficial for chronic OVCF with ongoing pain. So VERTOS V confirmed this benefit, especially with strict selection criteria and confirmed bone edema on MRI. And unlike earlier studies, VERTOS V was the first blinded randomized controlled trial ensuring robust evidence on PV efficacy for chronic OVCF. And here is just a brief recap of the key findings for the VERTOS V study. Basically, PV significantly reduced pain. It also improved health-related quality of life, and there were no significant differences found in the functionality between two groups. All right, discussion continue. Combining results from previous trials, such as VERTOS II and VERTOS IV, there were significantly more patients in the conservative and sham treatment group that continued to develop chronic back pain. This could possibly be a result of incomplete healing of their fractures. And they also found that these participants has higher pain score at 12 months follow-up compared to those in PV group. So from that, they found 5 predictors of poor outcomes, and they are female sex, high baseline VAS scores of 8 or greater, pain duration longer than 3 weeks until treatments, fracture severity, and new fractures. And these were identified as predictors of ongoing pain, indicating that PV might be particularly useful when dealing with incomplete healing. And strength of this trial. The strength of this trial is that nearly all participants, 94%, believed that they received the actual cement injection, even those in the placebo group. So this shows that the placebo effect or the expectation of pain relief was very high in this trial. However, even with this strong placebo effect, PV still performs significantly better than the placebo in reducing pain and improving health-related quality of life. So this suggests that PV offers real benefits beyond just the psychological impact of thinking they were treated. So that was the strengths. So let's now discuss some limitations of this study. The first limitation of this study is it included only 80 participants. While this was enough to detect a large difference in pain scores, it may not have been enough to detect smaller but still clinically significant differences. In addition to that, the active control of lidocaine and bupivacaine may have been insufficient to fully compare PV with a true sham interventions. So this can limit how well they can isolate the effects of the cementation procedure itself. Adding to that, the pain reduction differences were marginally below clinical significance threshold. This study defines the clinically significant pain relief threshold as a reduction of 1.5 points on the visual analog scale from baseline. However, the actual difference observed in the study fell slightly below this value at being 1.3. So this means that while the results were statistically significant, they may not translate to a meaningful improvement for patients. And the last limitations has to do with generalizability. Because finding applies only to chronic painful OVCF lasting more than 3 months, it may not extend to acute cases. And future directions. So PV was superior to active control for pain relief and improving quality of life in chronic painful OVCF. So future research should focus on comparing PV with a true sham interventions over a longer follow-up period, more than 1 year, ideally. Oh, I'm done. So thank you so much for your attention. Do you guys have any questions for us? We can start the Q&A session now.
Thank you, guys.
Excellent job. I really enjoyed that. It was a very good presentation and a very, very important study. I'm glad we were able to review it. We'll take any questions if anyone has one.
Yeah, Dr. DeVillipo, do you ever have any, because of the original Bushbinder Economies articles in the NEJM and where it didn't show benefit in sham comparison, do you ever get pushback from insurance pre-op for osteoporotic compression fractures?
Excellent question, Dr. V. Absolutely. Yes, all the time. In fact, that's why this study is so important, because we need research like this to help change guidelines, medical policies for insurance companies. And when you talk about vertebral compression fractures, we're talking about generally older individuals. And the biggest insurance for older individuals, especially over the age of 65, is going to be Medicare. And the way Medicare works in our country is there are actually different rules for who qualifies for a certain type of procedure depending on the geography in which you live in. So for instance, where I'm located in the middle of the country, we have a Medicare administrator that sets forth guidelines. And how the guidelines are created and what criteria are required often is very political, and they could vary tremendously depending on where you are. So where I live in Missouri, it's Medicare only covers kyphoplasty or vertebroplasty or mechanical augmentation. Those are all forms of treatment of vertebral body fractures. Vertebral augmentation is a general term. It only covers these procedures for patients who have evidence of bone marrow edema on an MRI or a nuclear medicine bone scan with increased uptake. And you have to have reported clinical history, being that symptoms started less than 6 weeks. So it's pretty strict. So where I live, I wouldn't be able to get a procedure like this approved. You can try to push for it in certain circumstances, but it's very limiting. Hopefully with research like this, we can change that.
Awesome, thank you. We have a question in the chat. Have the parameters for selection criteria in which patients to exclude for the studies, like cardiovascular disease or coagulopathies, have these parameters guided patient selection in practice to a significant extent?
That's a really good question. In fact, this actually came up in my own practice just this past week, where I have a patient with a pretty low EF, and he's definitely had some pretty significant cardiovascular events in the past, multiple stents, ended up getting a bypass, definitely had ischemia, resulting in a low EF. And you might think about this patient with the low EF and consider, well, in a trial like this, perhaps they'd be excluded. But in real life, what are you going to do? You need to do everything, I believe, possible to treat these patients when indicated, because really the effects of these vertebral body compression fractures are pretty severe. And what's perhaps not apparent to many people is there's actually a mortality benefit when you perform this procedure. I believe the number needed to treat is 15. So you need to treat about 15 of these patients to save one life. That's actually quite good. There are not a lot of things we can do in modern medicine that have that same effect, which is why this is so powerful. So for me, it doesn't stop me. If I have a patient with pretty bad cardiovascular risk factors, I will still treat them. In fact, I've done these patients under local anesthesia alone, which is why I made some of those comments in the chat about lidocaine and bupivacaine, because you can do it. It's challenging. It goes against convention, but those of us who do the highest volume of these do that routinely, actually. So it's quite possible. Coagulopathy is a little bit more challenging to deal with. There is a risk of bleeding, especially when you're working around the pedicle. You try to avoid breaching the medial board of the pedicle. If you were to get close, or if something were to happen, a coagulopathy could result in in hemorrhage in the spinal canal. That could be catastrophic. So we're a little bit more strict about that. But at least when it comes to sedation and cardiovascular risk factors, we try our best to work around it.
How do you garner these referrals?
Great question. So referrals are actually it's the hardest thing in interventional radiology. So for those of you thinking about this field, you have to think very strongly about this, because these patients don't fall on your lap. In fact, most people have no idea what it is you're going to do for a living. Even your own family, they'll have no clue. Even your family who are other physicians will have no clue. Because what we do in interventional radiology, VIR, is very heterogeneous. We treat a variety of different conditions from head to toe. So when it comes to referrals, I try to approach this from the vantage point of what could I do to take headaches off of other people's plates, right? And there are certain physicians that we can help where other people can't. So for instance, places where I go for some of these referrals, I actually go to places like assisted living facilities, nursing homes, primary care. I actually also go to orthopedic surgeons. I go to, folks like that, because a lot of these types of folks don't want to deal with these issues. I think when it comes to the elderly population, assisted living, nursing homes, that's actually a great source for these patients, because you might think, well, if they're debilitated already in a nursing home, why would you want to do something like this? Well, what happens is, even if they've had a stroke or something else in the past and they need help in assisted living, if you don't do this procedure, what happens is these patients enter this downhill spiral. They have decreased respiratory excursion, they're susceptible to getting pneumonias, and they will pass away. And nobody actually sees that happen in real time, because it's a process that kind of unravels over the course of 3 to 6 months, maybe a year. Usually involves multiple hospitalizations, trips to the hospital. And if you're a hospital-based IR, you're only going to see them in that context. You may not get the global picture. So that's what I do. Primary care is very, very important. Oftentimes, when a patient has a fracture, what do primary care physicians do? They try to find an orthopedic surgeon. Well, I'll tell you right now, most spine surgeons don't want to deal with these issues. And it's not because they don't care about them or they think ill of these patients. For lack of better words, spine surgeons have bigger fish to fry. They're interested in doing surgery. And a lot of these patients aren't great surgical candidates for the reasons we mentioned. So what ends up happening is they end up going down this road where they may be referred to pain management. In many communities, interventional pain management is done by anesthesia or PNNR. A lot of those folks may not necessarily be comfortable doing vertebroplasty or kyphoplasty or mechanical augmentation. So these patients end up down this basically this path where they keep getting epidural steroid injections or other anesthetic injections to help alleviate pain, but it doesn't solve the underlying issue, which is actual instability in the spine. And cement could definitely change that. So I think working with certain physicians is helpful, but I think going to primary care and going to where the patients live is even more helpful.
And then what's your kind of follow-up algorithm for these patients after the intervention?
Great question. So my algorithm, I tend to keep it simple. The first thing I do is I see them back in 2 weeks. Then I see them back again at 3 months. And then I see them back annually. So that's how I approach it. The 2-week mark is very important for me because I want to address any post-operative issues, concerns. I'll say in my experience, the risk of serious complications from this is pretty low. I do believe it is actually one of the safer procedures that we can do in our specialty. But it can be a little painful, especially when you're taking a cannula and you're advancing it through a bone, especially if it's one that's acutely fractured. We use a mallet, and that could actually cause vibrations, and that could be quite disturbing for patients. And it's a 10-gauge cannula; it's not huge, but there's going to be soreness after the procedure. So oftentimes patients will get better. You'll see them ambulate better right after. Sometimes it's not quite as magical, where 1 minute you put in cement and the next minute you fix them. Sometimes it can take a few days or a week to kind of get better and have them improve their ambulation. So that 2-week follow-up for me is very important. And then at that point, I space it out. I think other factors to keep in mind is bone health. And I know Dr. V mentioned that in the chat. That's crucial. You don't want to just be putting in cement and being done. You need to address the underlying issue, which is osteoporosis. So vitamin D, bisphosphonates, very, very important. I think that's something that we can and should address. Not everybody in our specialty does. And I will say, when you go out and you go to your training programs, you may not see that. In fact, I did not see that. I had to learn some of that on my own. So that could be a little bit challenging, but it's an opportunity to address that, because what will happen invariably is if you treat one level, you will likely end up having to treat another level in the future. And it's not uncommon to see some patients who don't have their osteoporosis addressed you'll see a X-ray, a thoracolumbar spine X-ray, where every single level has cement from like T5 to L5. It's like this cascade that you see. And I think, these are clear opportunities to address the underlying issue.
Sorry, go ahead, Dr. B.
No, one other question. When you see a patient with osteoporosis, elderly patient, vascular components, do they have other pathologies, either BPH or knee pain, or or even claudication or venous disease, superficial or deep, that you may have to address, or how does that work?
Yes to all of the above. So, it's the silver tsunami, as Doug Beal likes to say. We have an aging population, and it just so happens that the most common things that we're able to treat in our field are in elderly people. And so, I'll start off the bat. The first thing is venous disease. So venous disease is more common than just about anything you will ever see. But the likelihood of any of us, and this is not to speak ill of anyone, this is just a reflection of our field, the likelihood of actually learning about venous disease, not just DVT treatment, but chronic venous insufficiency and training, is pretty low, actually. So keep this in mind. But 50%. So invariably, you will see patients with leg swelling. They'll have venous stasis changes. They'll be debilitated because of that. And then you add on their back fracture, then it's an issue. So venous disease for sure. So one thing I always do, and I tell my medical assistant this in clinic, every patient I have who comes to my clinic, I take their shoes off. Shoes need to come off. You need to look for edema. Edema is very common. I simply just take a finger and just pinch right by the medial malleolus and see if there's edema. And if there's edema, then you got to figure it out. And I will say the vast majority of times it will be venous insufficiency. So there's that. Peripheral arterial disease. A lot of patients will have PAD. A lot of patients will end up in a spine surgeon's office thinking that they have a back problem when actually what they have is aortic disease. So pulse exam, very important. So another reason why shoes need to come off. So there's that. Knee pain, osteoarthritis, very, very, very common. Now, the mainstay treatment for osteoarthritis when it gets advanced are knee replacements, but what about all those patients who are intermediate? They don't have a lot of great options, steroid injections, or oral analgesia, NSAIDs, et cetera. And these treatments aren't great. We have an emerging treatment in our field, genicular artery embolization, which could work. We still have a lot of data that needs to be collected, but it's an opportunity to potentially address that. A lot of these patients may not be operative candidates. We talked about PAD, venous disease, BPH for men, very common. Lots of patients are getting up at night to urinate. I just make it a habit in my office for every male. I hand out an IPSS, International Prostate Severity Score. I use that to essentially screen men and at least have the conversation. Not everybody needs treatment, but you'd be surprised. You end up finding a lot of people who are not getting what they want. A lot of urologists don't necessarily want to touch a lot of elderly folks with comorbidities, but we have an opportunity to help there. So these are all things that you can and should do in a clinic. And I think to me, that's why clinic is so important, because these are all things I never learned, but they're actual opportunities to help patients. And, 1 minute you're talking about kyphoplasty, and here you are next minute talking about vascular disease, BPH, and all these other things. It's all related.
Yeah, great job, everybody. And in this study, it mentioned that one of the predictors for poor outcomes with the procedure was a high rating on the pain scale, and it suggested maybe kind of letting the compression fracture heal. I was wondering if you saw any feasibility in that, or if maybe doing the augmentation at that time, the vertebroplasty would reintroduce the fractures and kind of potentiate the effects, or kind of just what that looked like in general.
That's a really good question. So, the New England Journal trials that came out in 2008 and 2009, unfortunately, did a lot of harm for our cause as interventionalists. I think one of the critiques of those studies, and by the way, to summarize, I know we talked about it earlier, but those studies were negative. Those studies did not show that vertebroplasty had an advantage compared to sham, and therefore, almost now 20 years later, there's this myth that's perpetuated that these trials or these procedures are not helpful. I think we learned a few things. I think there is truth to the fact that if you let a fracture heal, there may be a point where it no longer hurts. And I think we see that in the data. There's no question about it. We see a reduction in the VAS, even in the sham group. And the sham group was truly intended to be a sham group. The only reason they dropped the needle and injected anesthetic is because they had to pretend to do something, right? That's why 94% or whatever thought they actually got something done, because it's simulating what we would do before we put a cannula in. But you get a reduction in pain score. But I think what this study may not actually show, because the numbers are kind of small, is a lot of patients won't make it to healing. They'll just die. Seriously, they'll just die. Which is why I think it's so important that when we identify these fractures and we're able to do so in the acute stage, we go ahead and treat them. Practically speaking, most of you, unless we have robust data that comes out and then we navigate the politics to actually get the right people who create the guidelines that support these types of interventions in chronic patients, a lot of you might be stuck with the way I'm stuck right now and Dr. V stuck right now, where we have to mostly treat acute patients. And I think the opportunity there is there. We have to be aggressive. I think the New England Journal trials were not positive because personally, I don't think they use enough cement. I think if you look at some of those trials, they're 2-3 cc's. There were vertebroplasty. I think there's good data that we can be very safe with kyphoplasty and mechanical. That allows us to actually have more support of the vertebral body, restore height, and actually inject more cement, which stabilizes the fracture. Imaging is very important too. I think you need to understand the acuity of the fracture. A CT or a plain film is not going to cut it. MRI is helpful. That is the best modality to look for bone marrow edema. That is a predictor, so we like that. Some patients can't get it due to pacemakers or other hardware. That's where a nuclear medicine bone scan can kind of be a relatively cheap way of trying to assess that. Not perfect, but that's why the guidelines are what they are. So I think for those reasons, it's very important. I think technique's important, patient selection is important, but the mortality is what people forget about. So I think to get to your question, I think, yeah, I would intervene for that reason alone, because what happens is it's a mess. These patients can't move, they can't go anywhere. If they live at home and if they don't have family, they don't have support, they need in-home care, it just becomes a huge drain, and they end up with pneumonias and pressure ulcers and all sorts of problems. So I think the biggest thing I tell patients is you need two things to happen. You need to walk and you need to get away from doctors, and that's how you live for a long time.
Yeah, it's sadly fascinating. Thank you for your input.
Of course.
I had a quick question kind of about, obviously the VERTOS trials have this like kind of rich history of weird, like, I'm not just VERTOS, but all these trials kind of around vertebroplasty and vertebral augmentation kind of have this weird back and forth going. And then kind of on the medical side or on the insurance side, there's also like this kind of like these stringent policies about who really qualifies for these procedures and who can really get referred, and the whole process around that to get to the stage of even getting the augmentation. I'm just curious, is this something that would be like rectified with like further research that just expands the patient criteria? Or in that case, like what would even be the thing that would help, I guess, expand its use in patients, I guess, outside of, the kind of, I guess, narrower scope of whatever the VERTOS V patient criteria is, I suppose.
Another great question. So I think a couple of things. I think one, research, and two, politics, right? So one, with research, I think this trial is a great trial. I don't think the numbers are great though. I mean, I think there's some questions about selection. I think it is somewhat underpowered for some of these subgroup analyses. I think we need a larger trial. That's the first thing. So I think we need more data. But even with more data, and we see this in the history of our specialty, we can have the best data in the world and it still doesn't translate into that procedure being wide scale. Uterine fibroid embolization, for instance, we actually have really good data that we've had for 20 years at this point, but it still isn't, the go-to option. And that gets into politics. And politics matters here in this context because it's really politics for insurance criteria. And I think that's where we need more advocacy, and we need to translate that research, and we need to actually, translate that into meaningful policy changes. I think that's challenging, but I think it's necessary. That's definitely what needs to happen. I think the other thing that needs to happen is we need to definitely be more patient facing. So I think we need to take this treatment option directly to patients as best as we can. So I think for me, that goes beyond subspecialty referrals, right? You don't want just a spine surgeon sending you something or a neurosurgeon. You don't want to be doing, what are perceived as sloppy seconds for a surgeon, right? This kind of what happens in IR. We end up dealing with problems that other folks just don't want to deal with, other surgical subspecialists, for instance. I think that's where it's important we go to primary care. That's where it's important where we go as close to the source of the patient as possible. So I think that's important. But I think getting to your question, it's really research and then politics. So we need more research. I think this paper is a great paper. I think it's a good start. But I think there are questions about the methodologies that we talked about. I think there's questions too, perhaps about technique also. We're only talking about vertebroplasty. And it takes usually about, I think, generally a 2-point difference, at least for me, in the VAS scale to acknowledge a clinically meaningful difference. I think we were kind of close to that in this trial. So it's still, some people will look at it and say, okay, sure, the p-value was 0.02, but is that actually clinically significant? I kind of wonder if, we use balloons, kyphoplasty, or if we use mechanical techniques such as spine jack or Kiva, if that would make a difference in height restoration, alignment, posture, and chronic pain as a result of that. So those are all questions that I think also need to be answered in this context.
Yeah, absolutely. Thanks for that.
Of course.
Thank you everyone for all the amazing questions so far. Is there anyone else that has any questions? I would highly recommend, if you guys haven't already, to check out the chat, because Dr. Badicacheri and Dr. Devolapalli have some great pearls in there. Thank you guys for that. But otherwise, thank you all so much for attending. I don't want to take up too much of your evening. I know it's kind of getting late for those on the East Coast, but thank you guys for attending and a great session. Wonderful job, both Tan and Chelsea. And we'll put the recording of this up on our YouTube website shortly as well. All right. Have a good night, everyone.
Guys,
Thank
for
you,
coming.
everyone.
Thanks so much.
Have a good
Thank
night.
you.
Thank you.